So while you're having that little stretch, I'm going to jump backwards and forwards between the presentation and between my friend who you might be able to see that's lying behind me. So we're going to jump about a little bit. So obviously it's a long time to be in front of a laptop or a computer and looking at all these things. The first thing I'd like to say before we start is just a huge thank you. So a thank you, Gillian, everybody that's organised the event. It's such an honour to have had the invitation. So I'm absolutely thrilled to be here. But I also want to say thank you as a parent. So Nico's beautiful welcome, as soon as he said, his job title, I have a very, very special place in my heart for neurosurgeons, for people who, the therapists, the nurses, everybody that's involved when your life goes a little bit astray. So my daughter is now 25. She lives with a complex brain injury and learning disability as a result of a brain tumour which was diagnosed when she was 6 years old and a very significant stroke when she was 9. So I'm always very aware as I'm speaking that the only thing that separates me as a parent, kind of my two hats, if you like, is my parent hat and my professional hat. The only thing that separates all of us is luck and time, really. So without further ado, the other thing to say, Gillian, was when you said about knowing me years ago, I wouldn't have been any use to you years ago. So we can all relax and that regret of, I wish I'd known this a long time ago, I share that regret as well, because there's lots of things that I've done in my 30 years of thinking about supported lying that I now recognise as having been a mistake. So we shall start, and let me get my screen up and running. Here we go.
Share one.
No problem. Okay, so thank you so much for having me. What I'm going to be talking about today is supported lying and the effect of gravity. And hopefully by the end of this session, we will have at least more questions, possibly not all of the answers, but we will know some of the questions that I would be asking when I'm introduced to a child that I haven't met before. The things that, as Gillian was saying now, what's happening, knowing the right questions to ask, knowing the right evidence to gather, and then from that evidence, for what the child's body is telling us, that tells me what my intervention is going to be. So it's going to be right at the very end that I'm going to be thinking about the intervention, which I also understand as clinicians and as therapists. Usually it's like, but tell me where to put the equipment. Well, I'm not telling you where to put the equipment. We're going to start right back at the beginning. And we're going to think, first of all, about what it is, what's the problem we're trying to solve. But before we do that, listening to Gillian before, what struck me was, firstly, she was talking about being humble and that idea of wishing that, that regret of wishing that you'd known something previously. And one of the things that I sometimes come across when we talk about supported lying is I work with incredibly skilled clinicians, but supported lying might not be a thing that they have learned about while they were training. It may be something that they've picked up in their role, but they've not necessarily had formal training. And that can be very stressful. And I absolutely love this poem because it's something that I feel as a parent, and it's something that I know earlier in my career, I probably was this person. So just briefly, there is something I do not know that I am supposed to know. I don't know what it is, I don't know, and yet I am supposed to know. And I feel I look stupid if I seem both not to know it and not to know what it is I don't know. Therefore, I pretend to know it. This is nerve-wracking since I don't know what it is I must pretend to know, and therefore I pretend to know everything. And sometimes the clinicians that I work with, I can see a visible kind of, at the very beginning when we say there is no question that is too simple, there is no question that could be thought of as being a silly question when it comes to supported lying. So if you're unsure, please use the Q&A. If there's anything that I say that you want me to go over again, the whole point of this training exercise is a discussion, not just me kind of, spilling out all of the things that are in my head, and you blindly accepting those. The other thing that Gillian just mentioned was around co-production. And co-production, when Gillian was talking about this idea of working in partnership with a parent, with a child, and with a family, and co-production is defined as an equal and reciprocal relationship between a healthcare provider, nurse, doctor, therapist, whoever it is, and the child and family. And there's some great resources online, but it's just sometimes you don't necessarily know the word that you need to use, to find those things. So this term here, co-production, is one that's used a lot in the UK. And there are lots of videos on YouTube about it. There's lots of things. So if that's something that interests you, I just wanted to share that with you. So what we're going to think about, we're going to think of the patterns of distortion as related to the habitual lying position. So that's the position that a child, it may be the preferred position, we know when a child is very young. It may be a position that's adopted for safety, or it may be a compulsory position. That preferred position has become obligatory. So we need to understand the habitual lying posture, first of all. And that's what most of this session is going to be about. How we translate that knowledge into our assessment so that every child that we meet, we're using consistent language amongst our team, and we are using consistent clinical reasoning whenever we think about the lying posture. And if we're doing those two things, then the therapeutic force that we need to apply in lying becomes clear, okay? And it's very, hopefully, I talk about having a very clear line of sight between the theory, the assessment, and the intervention. So we need to tie those three things together in order to make sense of the intervention. And we need to walk the family through our reasoning in order to get to that point. And I just wanted again, Gillian, just listening to you before, the sense of, when you meet somebody years later and you didn't see what you wish you'd, now I meet people now and I have a really good idea of what I need to do to support them to protect their body, but I didn't previously. And this is a young man called James, and I just wanted to share that the world over, that sense of regret is it's real and it's hard, but it's also nothing compared to the regret of families when they learn this information. So for me, as a professional, I can come to a situation, I do my job and I go away again. For a family, that sense of, I wish I'd known that earlier, is really magnified. And it's traumatic to know that there was something that you might have been doing now that you could have done, 10 years ago. So this is the same person. This is James when he was 9 and when he's 19. So it's 10 years. And what we know now is that everything in this picture, in this picture of him a little bit later, all of the clues are in the first one. But it's helping us to recognize those clues, document those clues, share our understanding with the family. And if we can do that, then hopefully we will avoid this trap that he's fallen into later. A really quick history about me. This is me in the middle here. I was born in 1976. I'm going to show you a paper from 1976. So I am in the UK anyway, I am the same age as this intervention, as supported lying. This is me. This is my sister Anna, who I work very closely with. I have the best socks, I think you'll agree, although her frilly socks are quite impressive. And this is my mum and dad. So my dad was in the army. My mum calls herself a recovering physiotherapist. My dad, as an engineer, went on to develop lots and lots of equipment. He had like 2 careers in his lifetime. And all of these papers and chapters in books and things like that is all work that I've written over the years. So I have been around this field professionally about 30 years, but I kind of grew up in a very bizarre house. Yeah. Okay, so 24-hour postural care. So 24-hour postural care can be defined as the continuous, consistent support of a person's body day and night to protect body shape and function, improve comfort, and prevent complications like pressure injuries and contractures. And very interestingly, there is a paper that I'll share with Gillian later from a wonderful therapist called Jackie Casey. And her work recently shows that whilst today we're thinking about these kids at GMFCS 4 and 5, those most complicated kids, actually what we find is that postural asymmetry and pain from GMFCS 1 through to 5 is an issue. Okay, so I can share that paper with you a bit later. So we mustn't forget those kids that are not quite as complicated as those that we're thinking about here. So when we think about what 24-hour postural care looks like, we can split it up into these different categories. So we have daytime positioning, sitting, standing, lying, and mobility. And the lying is, during the daytime, is an opportunity for us to support children to learn a skill, to learn how to balance in lying in order that they introduce it at nighttime. And one of the traps that we fell into in the UK was that we started talking about sleep systems. And if nothing else today, I would encourage you not to use that terminology, because as soon as we talk about sleep systems, then immediately we've confined it to nighttime and we've tied together 2 very complicated areas of a child's life. So we've tied together their body shape and the support they need in lying with their sleep and the family sleep and all of those things that go along with that. So I would encourage you, if we're thinking about introducing supported lying, first of all, just ban the word sleep system. Just forget it, forget I mentioned it. We'll never speak of it again. So lying during the day in preparation for supported lying at night. I wish that I'd known that 25, 30 years ago. I wish that I'd had the courage to really challenge what was going on during the day. Because as a parent, I now know that nighttime's so complicated, you don't want to be introducing new stuff at night. Then we've transitioned to movement, and then we've equipment and assistive devices. All of these things together, we can think of as postural care. And one of the things that we've been trying to do in the UK is to think about, rather than think about a child's position, we are trying to think about the idea of postural exposure. So prolonged positions as a risk. So if we think here, every static position is exposure to gravity over time. And the risk comes about for that child's body in three elements. So it's how long are they in that position? What is their alignment in that position? Can they get out of that position independently? And since 1976, we've known that if we have unsupported lying for a very long period of time, we know that's a primary driver of body shape distortion. Just in terms of terminology, and again, I'll share the reference a little towards the end. You may not be able to see me, but I have a book here called The Keywords of Childhood Disability. It is an absolute tome. It is huge. But one of the things that we think about is the idea of compliance. Okay, and compliance and deformity, those sorts of words feature very, very strongly in this book as being really challenging for families. Okay, so we know that families go through very traumatic experiences with their children. And sometimes the language that we inadvertently use can also be quite negative and difficult for families. So I tend to talk about distortion, body shape distortion, or asymmetry, rather than speaking about deformity. Unfortunately, the literature has got a lot of work, terms around deformity. So we need to be clever in terms of the way that we look at literature searches and all those sorts of things. So then we have the idea that no position is neutral, no position is entirely positive and entirely negative, and that every position carries an inherent risk or benefit. And finally, we need to think about the risk of postural exposure alongside all of the other risks that these children face. So aspiration, thinking about pressure, thinking about reflux, their temperature regulation, and all of those other things. Pressure, and we think about pressure injury. So both pressure and posture are the same sides, are two sides of the same coin. So they're two consequences, potentially negative consequences of prolonged postural exposure. So if you're in one position for a very long period of time, both pressure and posture are going to be impacted. And I would argue that you're not doing pressure care well if you haven't got your postural care right, and you're not doing postural care right if you haven't got your pressure care right. So they're very much part of the same thing. They are not in conflict with one another. So the next thing we think about is around outcome. And we know that, well, because when we talk about risk, it's risk of what? So we know that for these children at GMFCS 4 and 5, there is an incredibly high risk of hip dislocation. And we know from work in the UK that there's a very, very high risk of aspiration pneumonia. So one of the biggest killers, we know from research in this country, one of the biggest killers of people with learning disabilities, intellectual disabilities. So we have epilepsy, we have sepsis, and we have aspiration pneumonia. Those are our big three killers. So anything we can do to protect a person's body shape, we know that then that will have a positive, hopefully a positive outcome with regards to other, kind of associated health needs. This is a great paper. Again, I will share this with Gillian so that she can share it with everybody at the end. But one of the things that we need to be thinking about I'm just moving you all out of the way because you're all just covering my screen. So one of the things that we need to think about is recent research. Okay, so there's some great work that's come from Ireland, as I said, with Jackie Casey. There's great work that's come from Sweden, and this is from the USA, looking at hip dislocation. And one of the things that I find challenging is when people think that there is one answer to these really, really complicated kids. And you saw from Gillian's videos there that it's not just about postural management, it's also about handling. It's also about communication and trust and relationships. It's going to also be about medical management, medication and surgical intervention, all those other things. So what we mustn't do is fall into a trap of thinking, if I get the postural management right, everything's going to be great. Things will be better, but we will still need to be working alongside our MDT colleagues because complex kids need us to all work together and bring our very best to each and every child. But here we have this idea around hip dislocation. The risk factors for producing this abnormal force environment include motor control, age, muscle tone and force, gross motor function, and this is the bit where I get really excited, and predominant thigh posture. And when we think about it, it makes so much sense, doesn't it? The leg, the thigh, acts as a lever on the hip joint. The way that we support the thigh is absolutely critical to protecting those beautiful hips. Right, so no matter where we are in the world, we need to start thinking about a balanced postural diet, which is what Gillian was talking about before around movement, around positioning. But no matter where we are, the body's the same, the need for movement is the same, and the hours in the day are the same. But what may change is the opportunities for a range of postural, postural interventions. So we think about supported lying, supported sitting, movement and participation, and standing. And what we're looking to create, when we think about our assessment, we're going to come on to think about the body in a minute. But the other thing we need to think about is what's happening for this child over 24 hours. So where is the balance? You know, if we are working really hard with this child when they're at school, in the UK, kids are in bed 3 times longer than they're in school. So unless, it's not to say, if you get bed right, forget school, it's to say, if we did both, all the good stuff at school and all the good stuff at night, overall we'll get a better outcome. And we know, as Gillian said there, we all know the ICF framework. So I'm not going to talk too much about it, but you know, tying this in to why do we want to do it? Where do you want to get to? You want to be in your wheelchair because you want to get to see the football, which hopefully we're going to win tonight. But why? And that's the thing that drives families, isn't it? Is getting to know their why is hugely important. So really brief history before we get on and meet my friend. And I'm not sharing this because the UK have got it right. What I'm sharing this for is because we have got so much wrong and we have so much still to learn. So I just want you to leapfrog us. You know, I want you to be like, right, okay, that's all in the bag in terms of the evidence base. We've got that, and then plow on with the next bit. So the key one, Fulford and Brown, 1976, position matters. And these papers I will share with Gillian. So early asymmetry becomes self-perpetuating and worsening. There is, at the end of this presentation, there's a link to the APCP guidance. So that's the Association of Paediatric Chartered Physiotherapists in the UK. And they recommend supported lying as soon as possible after birth. Okay, so as soon as there is a suspicion that that risk factor of being unable to get out of a position, as soon as that's there, we get in there with the supported lying. So we know that if we can understand the mechanism, then we can start to think about prevention. The next book, this is available on Amazon. It was so Goldsmith is my mum was the co-author of this book. The reason I share it with you is this idea that it's the concept that every single contact with a child's body is an opportunity to shape an outcome. So we have contact in terms of therapeutic intervention and the hands of the therapist, but we also have contact from every single piece of equipment. And if there is a period of time during a child's day where we have not provided that contact with the child's body, then that in itself will shape an outcome. Okay, so every single contact will shape an outcome. With the Goldsmith indices, I'll share a little bit about this in a second so that you can think about, you don't need to do the full measure, but you can understand the principle of the measure. And then the last one really is the Mansfield project, which as Gillian said, was published in Physiotherapy Journal in 2000. So that's looking at a system in order to deliver consistent postural care. So I said it was the last one, it wasn't quite the last one. The final one is the paper that John and I wrote. So my dad and I worked on this through the noughties, and then in 2010 published this paper looking at what's called the sternospinal line, which is this imaginary line that runs between the sternum and the spine. So I'm going to run through with you in a minute how we read that and then how we pull together that theory into our assessment in just a minute. So we're not going to talk about it in much detail just now. The confidential inquiry, this was our wake-up call to say we need to be doing this. And And what I would say is where we've got it wrong is we've acknowledged that we need to be doing it, but we haven't put in place the systems that allows therapists to do this easily. We're still making it very difficult for clinicians in terms of equipment provision and all those sorts of things. Okay, there are lots of textbooks that I've contributed to where you can find more information. Some of the information is around the model and how we use it in practice, and some of it is around system development. But again, I'll share all of those with Gillian. And the last one to share from in terms of resources that are out there, this is a fantastic referral tool. So we're going to go on in a minute to go through our assessment of the child's lying position, but we need to be able to document consistently so that when your colleagues come to your assessment of a child's lying position, they know exactly where to find the information. Speeds everything up, makes everything simpler, and we can go from there. So this is freely available. It's actually a tool that was developed for nurses who were referring, to their MDT colleagues, referring into therapists, because what they recognise is the better the referral, the better the therapist can hit the ground running if they've got a really good idea of what it is that they're coming into. Okay, so when we think about supported lying, one of the exercises that I do with every family that I work with is we will spend a little bit of time looking at the child in bed, and I place the child's chair at the foot of the bed, and we stand, so the child is in the bed, and we will stand with the chair in front of us, facing us, and then the child in the bed behind. And what we're looking for is whether or not it is a straightforward journey from the child's lying position to their seated position. And that's the terminology that I use when I'm working with families. What's the journey from there to there? And we talk about the seated position needs to be a matching jigsaw piece, a complementary jigsaw piece for the lying position. And if those two don't slot together beautifully, if the journey from here to here is complicated, I have to turn you over, I have to bring your legs in, I have to think about your head turn, I have to think about the fact you're going to have this lordosis, from this position to here. The more complicated that journey, the more likely it is that you're going to need the expertise of someone like Elsha. You may well need more complicated equipment, but also eventually you're going to lose that seated position. And we're going to end up with the person only able to be in lying. Okay, so the lying position wins. It's the if you had top trumps of it's the high scorer. It's the highest scoring on the number of hours. It's high scoring with regards to reduced muscle tone, which is a protective factor. Sometimes in terms of body shape, it's a really, really tricky position. So I show this presentation to families and I say, which one of these matches this seated position? And obviously we come to this position here. And it looks really simple, but there's a great paper from Jane Hamer over in New Zealand, and that would indicate that it's absolutely not simple. It's really hard for families to introduce supported lying at night. So I come back to the idea of, before we come anywhere near the night time, let's do all of our learning during the day. So these are all recognised areas that we from a body shape perspective, that we may see improvement if we get this right. So we could be thinking about reduce pain. We could be thinking about somebody's life being longer. We can think about, improved social interaction. And the reason that I share this slide is because I'll say that no matter who it is that you're talking to, what I have to do is I have to convince them that the thing I'm passionate about, that supported lying, is the thing that they should also be passionate about. So if I'm working with a speech and language therapist, They may well think that the lying position's got nothing to do with them. Surely that's the physio or the OT or whoever it is that does that stuff. So I have to take the time to ensure that I am convincing every member of the team, this is yours as well. Your outcomes depend on us getting this right as a team as well. It's not just something that only I'm interested in. And then the final thing, there are some really great resources, free resources available. And this comes from NES in Scotland. And it's a postural care module that you can download free of charge and work through all of the exercises. But one of the reason I share it with you is because anyone that's experienced in this field knows this pattern, that they know this process, that we start off simple, relatively straightforward in terms of being able to look at body shape, and things get more and more and more complicated. So what this is good for really is documenting that getting that feeling that we have and that experience that we have and saying, no, here it is. Where are we on this journey? So the child in front of us, where do they sit in here? How far along this path are they? Because that will change the intervention that we're thinking about. The supported lying intervention for a child with a relatively symmetrical body is very different from the intervention for a child with a very complex asymmetry. And we need to be confident about that we can do both, you know? What we mustn't do is get to a point where we think, oh no, this is too much, I'm too late, you know, there's nothing we can do. Okay, so I've been talking to you for 40 minutes, right? I'm just checking the time. So we're going to go and have a look at supported lying, all right? And this is the when I talked about that line of sight, we're going to think about the theory, how it drives the assessment, how the assessment drives the intervention, and how the intervention must be linked to our outcome. Because if it's not linked to an outcome, then like, how do we know if it's working? Okay, so my colleague was working with a group of therapists a couple of weeks ago, and she was saying, if you're on a map and you're looking at that map and you don't know where you start and you don't know where you want to go, you cannot complain about being lost. All right, so this is about saying, right, where are we starting from? Where do we hope to get to? What makes sense for us to get to there? And then we can come back and track that. So we're going to think about this sternospinal line, and I'm going to come back to you. I'm going to stop sharing for 1 second, just so that I can open up. There we go. Hopefully I'm a bit bigger for you now, hopefully. So there we go. There is our chest. And here we have got our sternospinal line. Very conveniently, a great big bolt that goes through the middle of my model skeleton. Obviously, it doesn't exist in life. It's an imaginary line. But what we're looking to do is read that line, because the orientation of it will tell us what's going to happen to this flexible structure. So here we've got from Eleanor's project, the hammy that many, many of you will know. And it has a sternospinal line. There we go. Hopefully you can see that little thread there. So it's a bit clearer on this one. So if we have a vertical sternospinal line, so this is a child lying in supine with a vertical sternospinal line. Chest wall mass at the top is unsupported. So we're thinking, when we think of a chest wall mass, we need to be thinking plus the negative intrapleural pressure in the chest. We're thinking for somebody my size, we think of that chest wall mass, it's about 7.8 kilos. And if you put somebody onto their tummy, then we need to be thinking about the weight that we have here, and we're up to then about 12 kilos onto an unstable, flexible structure. So that doesn't work, does it? You know, we don't, if we're building a house, then we need it on a nice, you know, we don't want flexibility. Sadly, we've got a flexible structure. So vertical sternospinal line, like this, we will see what we call a compression distortion. And the characteristics of that are that the sternum stays in the middle of the chest, but we see the chest becoming wider and flatter than it was previously. So that is a compression distortion. So if we're seeing someone with a vertical sternospinal line, but no support, then we predict compression. If they have a horizontal sternospinal line like that, hopefully you can see that, there's their horizontal sternospinal line. Again, we're going to get a compression distortion. So on your side, what we have is compression that way, all right? So we end up with a chest that is very narrow, but very deep. Again, the sternum stays in the middle. So those two are our compression distortions. So a flattening of the chest that way or a flattening of the chest that way. Incidentally, you tend to see symmetrical compression in very young children. But as soon as somebody starts to get a bit bigger, what they will often do is they will move their bottom shoulder around a bit, and then you start to bring in rotation. So it's unusual, very, very unusual to see pure compression in that direction in older children. Okay, you'll have started to see rotation as well. The other thing that you will see is that either at the top of the chest here or down in the lower ribs here, you will start to see grooves for those children that sleep in that position, okay? Because their arm will get stuck underneath them. So if the arm is coming across at the top, that's where you'll see that groove. If the arm is getting stuck underneath here, he does have longer arms, by the way, they fell off. But if it's getting stuck down here, then you will see a groove there, okay? And we'll start to see the chest mold around the arms. Now, most of the kids that you see, you're like, that's very interesting, Sarah, but actually most of the kids I see have rotation because most of the kids that I see have rotation as well. So now we think about a sternospinal line that is at an angle. Now we have a problem because we've that chest wall mass here on this unstable structure. And when we think about rotation, the chest and spine does not rotate like that. The spine does not come up and off the supporting surface. Instead, what happens is we will have the sternospinal line at an angle like that. So we've got somebody, let's say that they're windswept and they're lying like that. And what we see is gravity comes straight down and the rotation is like that, okay? So when we come up, that's where we end up with our scoliosis, and we end up with the sternum is no longer central, but over on one side. Often we'll get a rib flare at the bottom here, and on the opposite side, you're going to see a rib distortion here, and you'll see the shoulder blade and the rib cage sticking out at the back. Again, it makes it much more difficult in terms of seating, because then if you've a flat back chair, you'll be pushed over to one side by that distortion at the back. Is everybody happy with that idea of a sternospinal line? Yeah? Because you're going to be doing this in a second. You're going to be having a go, and I won't put anybody on the spot, but you're going to be having a go at this in a minute. Right. The next thing, do you know, I'm stopping again. I'll come back to you. The next thing that we think about, so we've got the chest, we've got the sternospinal line at the chest. The chest and the pelvis, we need to be thinking about always in relation to one another, okay? And what we're going to do now is we're going to think about typical children. So when we measure, so when we're measuring using the Goldsmith indices, or when we're assessing against a 0. So if you've a ruler, every ruler has a 0 at the beginning. And what we think about is, what does a typical body structure look like, and how far has this young person moved away from that zero, if you like, and in what direction have they moved? That's essentially the assessment of their body symmetry in terms of what we're thinking about here, and we have to tie it back to where are they spending their time. Most of the time, those two things absolutely come together for children at GMFCS 4 and 5. It's a little bit more complicated for those kids with more voluntary movement. We can talk about that if we need to in a second. So let's go back. Hopefully everybody can see that now. So when we lie a typical child down and we have their knees to the ceiling, their pelvis will be level relative to the horizontal, and their sternum will be central. This is our zero, okay? This is knees upright. Where is the pelvis? When the pelvis is level, where is the sternum? So that's what we're looking for when we think about the lying position. And when we've got somebody that has full range of movement, now let me see if I can move you over a little bit. When we have someone with full range of movement, now this is Gemma who works in our office, and Gemma was a professional dancer, and she's a little bit of she performs. So you're going to see her perform in a minute. You'll spot when she starts performing, trust me. So with full range of movement, what we can see is that she can make full contact. I'm just going to go back a touch. What we can see here, she has full range of movement at her hips and her knees. And what that means is that she can make contact with the supporting surface from the top of her head down to her heels. What that means is that the supporting surface is supporting her. Okay? She's not holding her own body weight. So she can lie on her back and she can make full contact with the supporting surface. She can turn over onto her side and she's making full contact with the supporting surface. But what you'll notice is that even if she's got full range of movement at her hips and her knees, she has to flex. She's got no choice but to flex because she needs to balance. And we don't lie on our side in an extended at hips and knees. It's just, if you try and do it, it's a crazy position. So what we do is we flex in order to have this nice low energy position. So if we have somebody with full range of movement and they're inside lying, then obviously we need to be thinking about that flexion. Let's move her on a bit. And then we can think about her going onto her tummy. And if she's got full range of movement, then she'll get onto her tummy. But if you watch her feet, there's a couple of things to watch. So if we watch her feet can either turn out, which will drive rotation, kind of external rotation, AB, and I always get the wrong way around, abduction, up towards her hips, or her feet can turn in, so we'll end up with internal rotation and adduction, or she can kick herself over into more of a windswept position. And the other thing that you'll notice, even with full range of movement, if you lie on your tummy, then you're going to be encouraging that head turn all the time for many thousands of hours. If you are working with a child who likes to be on their tummy, then straight away an alarm bell should be ringing that they may be a child that finds it really difficult to know where they are in the world. So they may be a child who really struggles with their proprioceptive sense. So not only do we need to think about the position for that child, we also need to think about their sensory needs. Because unless we do both things for them, they will desperately want to get themselves back onto that compressed tummy position. So now let's give our beautiful Gemma a little bit of hip and knee flexion. So hopefully the first thing that you've seen is that the supporting surface is no longer supporting Gemma for about, well, what would we say? Possibly a third of her body in terms of her, maybe even a bit more. Should we say half? I don't know what it is. But look at this gap here. So what this means is the bed is not taking responsibility for Gemma. It's not providing the support. The supporting surface is not supporting. Instead, Gemma is holding her own body weight. So one of the things that people get nervous about is the idea of introducing flexion at night time, because they have this sense that a child's very flexed during the day. We need as much extension as possible at night. And we'll go into why. I understand that thinking, but actually we all sleep flexed. And there is a very big difference between unsupported flexion, which this is, and supported flexion, which we'll think about later. So no matter her diagnosis, so Gemma could have, she could have cerebral palsy, she could have muscular dystrophy, she could have dementia, you know, like we work with people of all ages. The diagnosis isn't necessarily the biggest thing in my mind when I meet somebody. What I'm thinking about is this surface supporting you? As soon as you've got hip and knee flexion, then you need to be thinking about how do we bring the support to the person rather than expecting the person to go to the support. So here Gemma's got no choice but to either turn her legs to one side, so her legs could fall to one side, they could fall out, or they can turn in. And that's not because she has cerebral palsy. It's because she's got to hold on to her legs. She's got to hold the weight of her legs. So they can fall to the side, they can fall out, or they can turn in. On her side, we're going to get more flexion. And on her tummy, look, if she has hip and knee flexion, her bottom will stick up in the air unless she just twists herself over to one side. Again, we've got that windswept position, the head turn, the lordosis, the leg position. That's you know, really difficult. Then this is not a jigsaw puzzle piece that matches a seated position. Okay, so what we're going to do now, we're going to think about, so we can think about the idea of the seeds of body shape distortion. They are sown at night. So one of the other challenges that we have is the growth hormone. Kids do their growing at night. It's when their growth hormone is secreted. So if we think about children as beautiful, stunning sunflowers, they need the support at night in order to grow symmetrically. And if we miss nighttime, that's going to be really difficult. So nighttime is very important, but if we make it so challenging for families that they can't do it, then we'll miss an opportunity, which again is about why coming back to the daytime is so key. So we've had a couple of minutes break. Hopefully everybody is okay. And what we're going to do, I'm going to introduce my colleague Steve, my other friend I have removed, and I've got my colleague Steve who is going to do a little bit of modelling for us. There he is. He's thrilled about that. He was. I just put my head into the office and I said, "Will you help?" He said, "Absolutely, I will. I'll stop what I'm doing." Right. So what we're going to do, we're going to do a quick exercise. I'm going to show you just, let me just share my screen for 1 second. So this is what we're going to do now. When we think about a lying position, we think about 3 layers of description for that position. The top layer of description is whether it's supine, so on your back, side lying, or prone. But it's a very broad description. Then we think about the direction to which the person is wind sweeping. And we're going to think a little bit more about wind sweeping in a minute, because wind sweeping happens in all unsupported lying positions. Then we're going to think about reading that sternospinal line. And I'm going to show you how to do it in just a second. So this exercise that I'm going to do with you is a really good one to do with parents, okay? So it helps them to see how the child's leg position influences what's happening at the chest. And I'm going to demonstrate it with you with Steve. We're going to think about how the chest responds to movement of the legs. We're going to think about whether applying an external force is going to be enough. And we're going to think about whether we can switch that driver on and off. Okay, so that's what we're going to do now. And I'm going to switch over to that camera. There's our Steve. Okay, jump onto here. Yes, please. So what we're going to do, can you look at those little beautiful British legs? There we are.
Marathon legs, they are.
They are marathon legs. I'll share some photos with you later of the sort of stuff Steve does. Yeah, he does. Right. Lie the parent down. So when we're thinking about training, we're thinking about teaching families principles, okay? Because they can take those principles with them and their child might change, but they have those principles to fall back on. So what we do is we have the parent lying down with their knees upright. And what we ask the other people in the room to do is to hold. Can you put your hands down by your side? We ask them to hold on to the chest, okay? And we ask, can you feel any movement in the chest? So we're looking at where the sternum is. You're a tiny bit wonky, aren't you? So straight away, we're looking here. We're looking to see where is the sternum, and we're holding the chest, and we say, right, can you feel any rotation in the chest with the knees upright and still? There should be none. Obviously, we are allowing him to breathe. What happens then if he takes his legs over to one side? And what we feel and what you hopefully can see is that we've now switched on rotation in the chest. And hopefully you can see if he brings his knees up and then takes them over again, hopefully what you can see is that the chest goes with the knees. So the direction that the legs are going gives us the direction the chest is going to go. Now what we're going to do, if you come back up again, we say to the parent, right, what we want to do now is we're going to stop that rotation in your chest, and we're going to do it by applying an external force. So we're going to hold on to your chest and then take your legs over, Steve, and we're going to try and hold on to the chest. And we can't do it, okay? Because it's an internal force where the legs are going with the chest following, and we can't apply an external force if we're not looking at the legs. So if we come up again, the last one we're going to do is we're going to switch that rotation on and off. So at the moment, we would be saying to the parent, is there rotation? No. So the rotational force is off. Okay, take the legs over to the side. There. Okay, come back up again. And then go over again, there. So when does it switch on and when does it switch off? And we're helping them to understand what we do here in the lying position impacts what's going on here. The last thing I want to do is just to show you. Can you see my pen? It's probably not. If I had some sort of great big stick, it would probably be better, but I don't. So what we're thinking about is that sternospinal line. So with Steve lying with his knees upright, his pelvis is level relative to the horizontal, and his sternum is, we're going to say it's central. He's a tiny bit wonky, but we're going to say it's central. So if I was to gently push my pen through his sternum and through to his spine, I'm not allowed to do that apparently. So rather you didn't. So if I was to gently do that, where would my pen end up? Where does the sternospinal line end up? If it's vertical, if he's in his habitual position and that sternospine is vertical, sternospinal line is vertical, then I know that what I need to do is I need to provide support here to prevent compression. I need to get partly underneath him and prevent that compression. If my sternospinal line is running at an angle, then I know I need to bring that sternospinal line upright if I'm looking at introducing a therapeutic force. So if Steve's legs, when we think about wind sweeping, if we take him over one way, his legs are going towards his right. His pelvis will over time drop back in this direction. So the legs go one way, the the pelvis comes the other. And we know that the chest will follow the legs. Now, looking from where you are, I want you to imagine a clock above Steve. And that sternospinal line, we always assess the lying position from where you guys are. When we look at that sternospinal line, it is going anti-clockwise, okay? And we'll come back and we'll think about that in terms of seating in a minute. Trust me, windswept to the right, anti-clockwise sternospinal line. And if he comes back over this way, we take that sternospinal line through the vertical and now over towards me, and we have clockwise chest rotation. So a classic windswept posture, if it's to the left, we have clockwise chest rotation. And if it's to the right, we have anti-clockwise chest rotation from the perspective of where you are standing at the end of the bed. Okay? So if you are used to, in a seated position, being behind the person and thinking about clockwise, anti-clockwise, unfortunately, it's the other way around. All right? So you need to be very clear where it is that, where is your perspective that you are looking at this rotation of the chest. Okay, sorted? Anybody got any questions before Steve goes and does some, there we go, no questions at the second. At the moment, yeah, brilliant.
Right.
Yep, thank you. Thank you. Oh, right. All good? Where are we? Okay. So now we're going to come to, so as I said before, having these standard exercises that you can do with families to say, the reason that I'd really like to look at this lying position is not to just give you more jobs. It's just, can you see how the body, we need to protect him from the very top of his head down to the very tips of his toes. So we need to think about the whole of his body. So wind sweeping. We're thinking about the influence of the whole position, okay? Because unless we've had incredibly early bilateral hip dislocation, then we sometimes do see a bit of a disconnect between top and bottom. But what we're looking at is wind sweeping is a whole body phenomenon. And we talk about classic windswept postures, and we talk about type 1 windswept postures. There is a difference between the two, and we can go into that in just a second. For those children that Gillian was talking about before who are dystonic, we need to be very careful in our assessment, because if we've provided the child with a flat surface that they can't balance on, what we will see is that dystonic movement, and we'll see torsion. So we'll see the legs going in one direction and the chest going in the opposite direction. But when we get that child under control in terms of providing them with lots of support, as you saw, you know, in those beautiful pictures, in lying, then we can assess their body shape by looking for the bony markers that we would look for in children who don't have dystonia. And what we often find is that if they're on a flat surface, they will give you like a torsion, they will give you that pattern. But when we get them really well supported, there are the signs within their body that they are classically windswept. Okay, so they can be quite difficult to assess. So classic windswept occurs in all unsupported lying positions, which you know, kind of whenever I say to a clinician, show me a windswept position, they invariably go to supine. Okay, so and then sometimes they will struggle because they're not used to reading a lying position in side lying or prone and thinking about wind sweeping in the same way. It just is something that comes with practice. So in terms of terminology, we think of the person being windswept to their left, and their right. which for somebody like me who struggles with their left and right, it's always a challenge. It will always be a challenge for me. But I find it really helpful to think of, rather than thinking of just that the legs fall to one side, I always say the legs fall to, are drawn to, or are forced to the person's left or the person's right. So the legs fall to, are drawn to, are forced to the person's left or right. The pelvis goes in the opposite direction. And for somebody who is classically windswept, their chest will follow their legs. And then we think about movement. So if we look at someone with typical movement, what we see, and this is where people may struggle a bit, is that the legs come over to one side and her pelvis rises on the opposite side. And then if she goes over the other way, we come back through neutral, through the level pelvis, and then we come up. The legs go over to one side, pelvis comes up on the opposite side. So as well as thinking about structure, we also need to think about movement and asymmetric movement. Asymmetry of movement comes before asymmetry of structure. So if we can catch children when they are showing us their asymmetric movement before they have the scoliosis, before they have the pelvic tilt and the obliquity and the rotation, if we can catch them then, like that saves us a whole world of difficulty. So we're looking at structure. When the knees are upright, is the pelvis level? When the pelvis is level, is the sternum central? So we can look at those bony markers as part of our assessment. And the other part of our assessment is to take the child's legs from side to side, and we will feel that they go much more easily one way than the other. And that's the side to which they are windswept. So the way that we assess it when we have the tools that we need in order to measure the position of the pelvis, the question we ask is, when your knees are upright, is your pelvis level? If the answer is yes, then we're all good. We then look at the chest. If, when your knees are upright, your pelvis is not level, one side is higher than the other, the side that is higher is the side to which the child is windswept. So when the knees are upright, is the pelvis level? If the answer is no, and the pelvis is up relative to the horizontal, is higher on one side than the other, the side to which the pelvis is higher is the side to which they are structurally windswept. So we need to level that pelvis, and then we look at the chest. All right, and I'll share a YouTube link that goes through all of this in detail, so you don't need to like have it in your head now.
Okay, go to your right.
Oh,
That's it.
Can you hear me? That's me wittering on at my daughter. So this is my daughter. This is before she was a teenager. So the thought that she would do this now is completely alien to me. She's decided, no, she's not going to help me with these things anymore. She'll come round again. She's the youngest of four, so I know she'll come round again in the end. She'll talk to me one day. Okay, so what we are looking for is something called the ab lap, the angle between the legs and the pelvis. And in a typical child, you will see the response at the pelvis is the same on either side. So legs go over to one side, pelvis comes up. When you take them in the opposite direction, legs over to the other side, the pelvis will respond in a very similar way. So that's what we talk about. That's what we're thinking of when we talk about symmetrical movement at the legs and pelvis. If a child is becoming asymmetric, what we see is their legs fall much more easily to one side, and we don't get the response at the pelvis. So the legs go over and over and over and over, pelvis hardly responds. But when we take them in the other direction, the legs don't want to go that way and the pelvis comes straight up. Okay, so that angle between legs and pelvis in someone who's windswept right is much bigger than when you try to take them to the left, and vice versa if they're windswept left. Okay, the angle is much bigger. And if you get lost, in terms of your, kind of when you're thinking about this through for the first few times that you do it, just go to the extreme in your head. So if you're working with a 2-year-old and you're like, I can't quite remember which way around it was, because it's not as obvious, it's much more subtle in a 2-year-old, a 3-year-old. Just think about the 30-year-olds that you know, okay, whose legs fall absolutely down to the supporting surface and their pelvis is level. Think how big that ab lap is. So what I'd like you to do, I would like you, and we can use, I don't know, think there isn't a chat function, but there is a Q&A function. So rather than ask a question, I would like you just to have a little go at this. So what I'd like you to do, you're getting no prizes for the fact that they're all in supine. So do you remember that was our headline? Supine, side lying or prone. So no prizes, they're in supine. What direction are they wind sweeping? And which direction is the chest rotating? So have a quick go. You could do it anonymously, I think, in the chat if you're feeling a bit I'm trying to see if I can see. I don't know if I can even see the chat when I'm in this. Who knows? Maybe Gillian can see the chat.
No one's given any answers yet.
Ah, so one thing you should know about me is that I was a teacher for 5 years in Aston in Birmingham. Gillian, you said I was in London. I avoid London at all costs. It's far too busy for me. I'm in Birmingham. So I used to teach in Birmingham, in the first school in the UK that had a permanent police presence. So if the school was open, we had police on site. So silence doesn't frighten me. Have a go. Right.
Okay,
Is it
so
time?
someone's saying windswept to the right.
Yes.
2 people are
Bang
saying
on.
windswept to the right.
Perfect.
Top left is windswept to the right.
Perfect. And which direction is the chest rotating? Clockwise or anti-clockwise? Imagine a clock above their chest. Look at the direction in which that, if you were to gently stab your pen through each of these beautiful chests, what direction would your pen be? Anti-clockwise or clockwise?
No answers yet. Nope.
I've seen a couple.
Oh, hold on.
So,
No. I've missed a whole lot of answers here. Clockwise.
okay.
So no, we've got 2 people saying clockwise, 2 people saying anti-clockwise.
That's what we like. Okay, so what I'm going to do, just annotate here. If I were to take my pen, so if we think we've got a sternum's about here. So if we think xiphoid process, there we are. Someone's very kindly put, so we're probably going to be about there. Yeah, that's where we are. So if we think about the chest as a continuous shape, if we've the sternum moving over towards the person's right arm, then the spine is moving over towards their left. So if we were to gently stab our pen through to where we've got the person's spine, all of these individuals are anti-clockwise. Okay, so some of them more than others. So what we think about is that is the direction of chest rotation. So it can be easier sometimes to look at the windswept direction if you're not used to using this sternospinal line model. The windswept direction gives you a clue about which way the chest is likely to be going. But each of these individuals, when we think of this, what you're thinking about is this chest wall mass. It's heavy and it's on top of a really wobbly tower. So if we're offset, then we're heading over in that direction. Okay, so we are anti-clockwise in all of these. Which of these, so we've got 1, we've 2, we've 3, and we've 4. Which of these people is easiest to deal with regards to their seating? 1, 2, 3, or 4?
1. 2 people
Yep.
have said 1.
Okie dokie.
3 people have said 1. 4 people.
Ah,
No, someone has said 2.
100%.
No, sorry.
I-
1. Yeah, one person said 2. Everyone else has said 1.
So the answer is the person at the very beginning. So the 2-year-old. Oh, I'm trying to get rid of my annotation. And I'm trying to not be annotating. I'm going to close. There we go. Now I can use it. So here we have a 2-year-old. Here we have a 10-year-old. Here we have somebody in their 40s. Here we have somebody in their 30s. They should be the other way around, shouldn't they, really? The earlier that we can get in, the easier this is to deal with. Once we start getting to here, where we've got these starting to get structural changes, we're starting to see a more complicated relationship between the pelvis and the chest. This is where it starts to get more difficult. Here, really quite straightforward in order to introduce. We know the child's body is telling us, I'm going in this direction. So we can photograph, we can assess, and we can start to put in, a guide to bring them back. Okay. One of the things that I always talk to parents about is the idea of seeing their child's chest like a tower. So a tower needs to be upright, otherwise it's going to fall over. So none of these children have a stable upright tower. Their towers are all falling over towards their right arm. So if you're not using, it doesn't need to be complicated terminology. We just need to get their towers upright. Okay, because this is what typical children have. Typical children have a tower that's upright. So that's what we want to give to the child that's in front of us. And the more typical their body shape is, the more typical their participation is likely to be. So there we go, towers. So clockwise rotation, we are at the foot of the bed, looking up the body. Here is this unstable chest wall mass. You will tend to see, so if we just annotate here, you will tend to see a rib distortion for clockwise rotation. So we're going in that direction. So this is windswept left. So you will tend to see a rib flare here, and here is where you will see the ribs protrude and the shoulder blade protrude at the back. Okay, so they will tend to be forced to lean to their left in their seating. So in their lying, that tower is falling over. In their seating, it will be translated into a lateral bend. And what we tend to see as well is a narrowing of the gap between the lower ribs and the pelvis on the person's left. Okay, so what we're thinking about is how do we document that? How do we spot it, document it, and then prevent any further changes? Okay, so clockwise rotation, and that's what it looks like in life. So we look for where is the sternum. In terms of photography, I'll share with you just towards the end of the presentation the 3 photographs that I ask every family that works with me to provide prior to meeting with them so that I can get an idea of what's going on. But what we're looking for is sternum to lateral border, not down to the supporting surface. That measure is no use to you, okay? Because we've got lumps and bumps in the chest. We've got changes in the chest symmetry that make that measure really misleading potentially. Anti-clockwise rotation associated with classic windswept right, opposite direction. So there's your rib flare. That's where you'll see the rib distortion at the back. This is where you'll see the narrowing of the life box, Sharon Sutherland's life box. We'll see it on this side. Those individuals will tend to lean to their right. Okay, and that's what it would look like in life. So we're looking for sternum to lateral border. Okay, so what do you notice? So which way is the person wind sweeping? Left or right? Rapid fire. Stick it into the chat, super quick.
Left. Hold on, we've got both left, right, windswept to the left, left to the right, left.
Okay, so let's have a go. So what we're looking for is, this is the person's right and this is their left. And remember, we talked about the legs they fall to, they're drawn to, or they're forced to the person's left or right. So for this individual, her legs are heading over towards her right. Her pelvis will go in the opposite direction and her sternospinal line is running at that angle. And so we're going to have anti-clockwise rotation, which we see here. Okay, so if that's 12 o'clock, there we go. And that's 1 and that's 11. She's heading over that way. All right, so she's classic windswept to her right with anti-clockwise chest rotation. Okay. So you're either going to be excited by the idea of doing this one that's a bit more complicated, or you're just thinking, enough now, because we're starting to get hungry, actually. Have a quick go. Remember the legs. So I'll give you a clue. Right, this is the person's, here we are, let me see. This is the person's left, and this is their right. I've already drawn the sternospinal line on for you. So the legs, they're not falling to, but they are being forced to one side. Anybody having a go?
Windswept to the left.
Brilliant. Windswept left, clockwise chest rotation. And it can be it's a habit to start getting into, to start using those 3 descriptors whenever you come across a child's habitual position, no matter how old they are. We start to say, right, in this position, supine, sideline, or prone, what direction are you wind sweeping? Which way is your chest rotating? And that helps us you just have to practice it over and over and over. So if you are unlucky or lucky enough to have somebody lying in bed next to you tonight, try, stand at the foot of the bed. Are they windswept left? Are they windswept right? What's happening to their chest? Okay, so windswept left, clockwise chest rotation. Okay, prone lying. Prone lying, you always get compression, you always get rotation. Okay, you do not meet people who simply compress in prone. There is always a rotational element. And it's because they invariably have hip and knee flexion, which means that they have to go into that kind of kicked over to one side position that Gemma showed us in the video. And they will also have a head turn. You know, it's very, very unusual to meet somebody who sleeps with their head straight into the pillow. So we've always got this compression and rotation. So if we look here, we can analyze in exactly the same way. So we can look at the legs. So this is the person's, now I need to, sorry, there we go. This is the person's right, this is the person's left. So their legs fall to, drawn to, forced to, they're forced to the person's right. And if we were to gently stab through, imagining where their sternum is going to be, then we've got anti-clockwise chest rotation. When they come up into sitting, one of the things that we need to be really mindful of with prone lying is that lordosis and prone lying are, they come hand in hand, they come together all the time. So we need to be very aware of that, particularly if we're trying to get somebody onto their back, and we're starting to think about supine lying. we can get to a point where that's very, very difficult because of a significant lordosis. So let's take a look at, okay. You can go on and on and on to do this, but I don't want to do that. What I want to do is show you some different positioning techniques in a minute. But each position that somebody's in, you're at the foot of the bed and you're working from the head down, supine, sideline, or prone. What's the wind sweeping direction that's going on? What's happening at the chest? And it's just practice and practice and practice. And when you start writing those down, it helps you to think about, if somebody is windswept left, then that helps us to think through what force do we need to apply at the legs in order to get to a more neutral position. If somebody is clockwise at the chest, what force do we need to bring them around to a more neutral position? So knowing what's happening tells you what your ideal therapeutic intervention is going to be. Okay. You've met all my children now, I think. Right. So these are the 3 photographs that I would strongly recommend you get into the habit of taking. This is just that QR code there will take you to a YouTube channel, which has got 6 videos that are purely about measurement of body symmetry. So whether you measure or not, they're well worth looking at because it goes through what we do when we have full measurement and how we analyse the results. So rather than just thinking about the feel of an ablap, we're able to measure the ablap and then compare what's happening over time. So you can take a look at those because what they will do is they'll give you a very good idea of, well, I don't have that kit, but I can understand what it is that measure looks for and think about ways that you can introduce that. So the 3 photographs that are really kind of, I would say, essential when you're thinking about monitoring progress. We want to see where is the child spending the majority of their time when they're lying. So we look at that position. We want to know what's happening at their life box. So lower ribs to ASIS either side. Have we got a beautiful rectangle? Have we got a triangle? What is it that's happening here? And Sharon Sutherland is the clinician that's got a lovely YouTube video all about that. And then what I want to look at is this shape here. Okay, I'm interested in where the sternum is, but I'm also interested to see whether I've got symmetry here and here, or whether I was working with a little girl on Monday night, and it was a very clear, she's 3 years old, a very clear indentation here, which is where her arm is getting stuck. So those are the 3 photos that I would routinely be taking alongside that kind of analysis of the 24 hours, where are we spending our time? Then what we think about, so we think about risk factors for the child, and we think about assessing the child's body shape. And then we think about where the risks are in the way that the service that supports them is organised. And you can do this it doesn't matter where you are or what your service looks like. You can think about this anywhere, but this is just for typically in the UK. This is what we would be thinking about for those risks. Wherever we've got a transition, so from one team to another team, so from one classroom to a new classroom, or one school to a new school, that to me is a risk, because we need to be very careful in thinking about how is this documentation going to follow the child so that the new people know as much as the people that are currently supporting the child. So these danger points are the same for you as they are for us here, okay? The danger points and the opportunities really are the same. So if we can get in really early and protect symmetry rather than correct asymmetry, that's a great thing. But then you may well have transitions that look different to those that I'm, used to working with. So our intervention, we've got the theory, we've thought about how we're analysing a person's habitual position, and now we're going to begin thinking about the intervention. So these are the postural opportunities. So it's sitting, it's standing, and it's lying. None of those is more important than the other, okay? They all need to be considered within that 24-hour period. But what we do know is that if any of those are either not so good or missing altogether in terms of support, then we know that that's going to have a negative impact on the outcome. And we need to be really mindful that most children that we assess appear as screws, okay? So this screw represents our rotational distortion, and this nail represents our compression distortions. Almost every child that I meet has both of these things going on. So if we have a positioning strategy that is purely lateral, and I'll come on to what I mean about that in a minute, then it means that you are treating the child as if they are a nail. And in lying, we have a brilliant opportunity to treat the child as if they are a screw, because we've the option of derotation in lying that we don't necessarily have in seating. So our assessment tells us, are we dealing with a screw? Are we dealing with a nail? We're probably dealing with both. What is our goal? Okay, is it just to keep us exactly where we are, or is it to unscrew things? Is it to turn back time a little? And then our equipment and our positioning strategy need to match what it is that we see. So here we are, thinking about how we introduce derotation. So we'll have a quick go at, let me start tying everything together. So this young man is windswept to his left, all right? If we were to gently put our pen through, we will have a sternospinal line in that direction, which means that he is rotating to his left. So we are clockwise in terms of the chest. And if we're not careful, we will end up with him going further and further and further over that way. So we know that we've got a structural change here. So it's not just a case. If he was symmetrical, I would be providing equal support, one there, and I would provide one there. And I'm going to show you those in just a minute. But he's already asymmetric. So there is his sternospinal line. And what we want to do is we want to get it upright. So the first thing that we do is we block this side of his body. And I'm going to show you the positioning technique in a second, but we roll him in the opposite direction. That's the direction he's going in. So we need to take him in the opposite direction, and then we need to block partly underneath his body here. And sternum central is the goal. And when we bring his sternum central, what we see is this rib distortion here that was hiding has now become really obvious to his mum. And that was a bit frightening, okay? Because she is so used to seeing her child in this position that when we start to mess around and we do this, she's like, that doesn't look right to me. That doesn't look natural to me. It doesn't look like my child. So the ideal thing that we do is we talk about that before we do this. So we will be saying, if we look here, can you see how he's got this little rib distortion here? That's going to become really clear in a minute. And can you see how his tower is falling over? And we're going to bring his tower upright. And then this bit, do you remember we said that that was going to happen? See how that's happened? We're not so worried about that at the moment because we've got his sternum nice and central. Okay? The tower is upright and the tower has got scaffolding either side to hold that chest wall mass up. Does that make sense? I'm going to come back to you all in just a second and find out if it makes sense. So this is the technique. So this is a young man called Elijah, who I've known for about 18 years now. Okay, so Elijah had he has Apert syndrome, but he had a surgery which he had an infection in his brain when he was 18 months old that wasn't picked up for 10 days. And so he has an acquired brain injury. So his Apert syndrome is not why he needs the positioning. The brain injury is why he needs the positioning. So hopefully you can start to see how these things all tie together with this windswept to the right position. That gap at the waist is narrowing on his right. So we have a lateral situation here, but we also have a rotational situation. So what we need to do is get that tower upright, and this is the way that we do that. So he is blocked on the one side, and we rotate him round, get that tower upright, and then provide the support. And this is a 25-year-old young man. So again, hopefully you're starting to see that we've got that sternospinal line, and we can see that we're gradually, so that's the direction of the distortion. This is the direction of the therapy. That's the direction of the distortion. That is the direction of the therapy. All right. So we're bringing him round so that he has that, that sternum central concept. And if we, I need to close that. And then finally, just to show you, so again, coming back to this idea of children at GMFCS 4 and 5, we know most when it comes to supported lying about children at GMFCS 4 and 5. But what we're starting to do is realise that there are a lot of children who access different services, but who also need supported lying. So this young man is called Taylor. And this is when I draw those when I draw the support on people. This is hang on. So when I draw the support, this is the support that I'm thinking of. So when I'm drawing it here, okay, so here we will have a set of laterals at his pelvis. Usually we have one set of laterals at the pelvis and one set at the chest. And if I take that lateral and I take it further underneath, hopefully you can see that I'll be providing more of a force in that direction. So the position of the lateral gives us either decompression or it can give us that derotation. Let me get rid of those. There we go. And there he is after 6 weeks of supported immersive supine lying. So he has to sleep on his tummy. I'm going to come back to you in just 1 second and let's have a quick talk about prone lying and the way that I explain that to families as being tricky. Just written that down so I don't forget. So hopefully you're starting to see, or you know, hopefully this is giving you a framework for what you already know in your bones. You know, any experienced clinician knows there's stuff about lying, and all this is about, it's not new information. It's just a model that helps us to organize our thoughts and to organize our assessment so that when we are discussing it with our colleagues, when we're thinking about intervention, we've got that consistency. I don't want anybody to think that I think that this is all new to people. I know that it's not. It's possibly new in the way that it's organised. So in terms of advice and support in South Africa, I know that you're hearing Daniel a little bit later. I think that's tomorrow. But Timian, we've worked with Timian for a long time through DDO. There is a presentation on the ISWP website that takes you through that work that we did. And the product that we use is called Nest, and it's from DDO, but it's with Simple Stuff Works. It's not a Simple Stuff Works product. It's not manufactured by us. It's not the same materials as we use, but it's the same principle. And then that guidance that I talked about the APCP is there as well. Other useful things on our website, there are a lot of resources. There is Wired on Development has a fantastic podcast. This podcast is all about parenting complex kids. If ever you've wondered what some parents talk about, not all parents by any stretch of the imagination, but some parents' experiences. And this one here, which is called Clinical Excellence Online, which is a pediatric therapist coaching platform. And that's that. Those are my contact details. That's my email address. And I'm very happy for people to get in touch. So training@simplestuffworks.co.uk. And I'm going to stop sharing that and come back to you. So we have got about 10 minutes. One thing I just wanted to say before is just about that prone lying idea. So when I talk about that with families, I talk about a lemon meringue pie, and I don't know how that's going to translate, Gillian.
Yep.
Lemon meringue pie?
In South Africa,
Yeah.
certainly. Yeah.
Perfect. So a lemon meringue pie, if we lie a child down and we imagine them as a lemon meringue pie, we've got that heavy base on the bottom, like a lemon meringue pie, light, fluffy stuff on top, delicate stuff on top. When they go into prone, we've put the heavy stuff on top and the light, fluffy stuff on the bottom. And so we see some of the most extreme compression in those children who lie habitually in prone. What we see first of all is that the lumbar spine will tend to dip forward, pulls the pelvis into an anterior tilt. That head turn then gives us that long asymmetric lordosis. The arm posture is just, it's a very typical posture. You all know those kids. So when I talk with families about it, you know, that's the sort of language that I use, is that we need to get this light, delicate part of his body on top, you know, and put this heavy stuff on the bottom, and then give him some scaffolding and potentially give some weight as well. And the most successful thing that I have found for children who are dystonic, or children who love prone, who desperately want to be in prone, is the sensory side. So we will often use weight, occasionally vibration as well, to give them a really good sense of where they are. And there's some brilliant work by a therapist in Belgium called Jo de Klerk, whose name I'll share with you, Gillian, who's been working with people with dementia. But there's a real crossover from that sensory side of things.
Posted earlier on, my daughter has, let me give you all three questions. My daughter has a slight scoliosis already. Can I do this for her? Question number 2, when can we not work on these postures anymore? Can we still influence them in adulthood?
Yep.
And then will you elaborate more on the actual interventions and how you correct the wind sweeping?
Yes, 100%. So the first question is that you are, so just looking, and so when you say your daughter has a slight scoliosis already, this is a perfect time to start. And the reason it's perfect time is because she's telling you where she's going. Yeah, things are starting to move. So now, like, you know where she's going. So we need to think about providing that support. So this is a beautiful time to start. When we can't work on these postures anymore, so when we've people who have very complex body shape, things change slightly, and it's tied into that third question, sorry, about how do we correct wind sweeping. So let's take a quick look. I'm not going to use Steve, only because none of you saw the look that he gave me when I said, Steve, can you come in here, please? And he was working, and he was like, oh. So I'm not going to do that again. I'm going to get my skeleton and just quickly show you, but we'll go to there. So can we see? Turn his feet round. Okay. I have no idea where his other arm is. It will be in that room somewhere. But not to worry, okay? Because we're going to focus here just for a minute. So he has a sternospinal line, which we have here. He's windswept to his left. This is his left, and this is his right. So he's windswept to his left. His chest is much firmer than, you know, the chest we're used to dealing with. But that would be the direction that the chest is going. So during our assessment, what we're looking for is, when I bring your knees upright. So when I bring your knees round, I'm trying to see whether when I bring your knees round, is your pelvis level? And that will tell us whether, from a positioning strategy, bringing the knees to the middle is the right thing to do for this pelvis. If what happens is when I bring the knees upright, the child moves as a block, yeah, and I end up with a pelvis, that's up round like this, then I'm being far too ambitious with my strategy. So what we need to do is, if our assessment says with the knees upright, the pelvis is level, and with potentially a little bit of derotation, I can get the sternum central, then our positioning strategy looks like this. But if we've somebody who is very windswept, so you've got a very narrow gap here, you've got that lateral deviation, and you've the rotation and the compression, then what we do is we think to ourselves, right, what do typical children have? When their knees are upright, their pelvis is level. So what we're going to do is we are going to bring the legs around until the pelvis is level and then support the legs there, rather than trying to come to somewhere that doesn't make sense. So we may bring the legs a little. The other positioning technique that we sometimes use is if we've got a very narrow gap here, so we'll have support at the pelvis, then we will move the legs to see where if we start to get a rise on the pelvis, that's where we stop, and we'll block with pillows or, whatever it is that we're using. The other thing that we can do is if we're working on opening this gap here, one thing we'll do is we will derotate the pelvis. So chest. So we block on one side. The way that we do that is we will go in between. This is the same as the nest, same principle as nest. So we will go in between these two strips of mesh. We will put the support in there, and then we will roll the chest round. That opens up here a little, and we'll block there. The other thing we can do, if we're strong enough, and if the person is small enough, if we want to open here, one of the things that we sometimes do is hand onto the left ASIS, and we will hold the legs, and what we will do is we will just bring the legs around and just open up a little bit here. So those would be they're probably quite ambitious for somebody. So never, not at night at the beginning. So we would think very much about doing this during the day. All right, so the degree of correction that you put in depends on your assessment of when the knees are upright, what happens to the pelvis. Too much correction, and you're going to lose. This is the part of the body that's keeping this person alive. Too much correction, and we start making life much more difficult up here. What you'll find, if he moves over a bit, what you'll find is that if you've not got enough, the other thing is that if you don't have enough flexion at the hips, what kids will do is they'll lift their legs up to try to reposition their lumbar spine, or they will push up out the bed and come back down again and get their pelvis tilted back where they want it. So all of those are little signs that we look for to see whether the position that we're coming to is one that's manageable for that child. So we're always ambitious. So we always start with what can we correct? Yeah, what force can we put in order to correct? And then the child will tell us whether that's too much for me, and sometimes so the young woman that you saw in the presentation who had that chest that was very distorted with the kind of rib cage that was protruding, we couldn't get her in supine because as soon as we did, she struggled to breathe. And so we end up with a situation where it's like we can't put in corrective force, but what we can do is still provide immersion and comfort and not let somebody's legs just fall over to one side for a long time.
Well, if you can do it in 5 minutes, that will be great. Or else we'll also can hold them on, but see what you can do in 5 minutes.
Yeah, okay. So anything to do with seating, the one thing I always say is that seating is too complicated for me. Lying is the thing that I have expertise in. Seating, I hand over to seating specialists. But what you see is a crossover. There is a carryover. The seated position is a shadow of the lying position. Yeah? So that it's the blueprint. The lying position is the blueprint for seating. The two are linked. So we need to think about them both together. In kids who love prone, what we need to think about is when we get them onto their backs, depending on where they are in terms of that pattern, they may well already have a significant lordosis. What we need to do is put in enough hip flexion to see what happens at the lumbar spine. It would ideally be after work, like Gillian was sharing with you previously, around movement. So having had some movement, having, kind of getting kids a little bit more relaxed, then thinking about what can we get in terms of some correction at the, in terms of anterior tilt at the pelvis. If you're able to get that right, I would always have weight, and always with dystonic kids, I use weight across their pelvis, not across their chest, but always across their pelvis, just to give them that sensory profile. When you do it during the day, how long do you position? As long as the child will let me know that they're comfortable. Comfort is the #1 priority. If a child says to you, I've had enough now, and you say, no, you're carrying on, I don't think that's what any of us went into any of this for, to kind of impose our will on people. So it's about how long can they manage and be led by the child. How much time do you typically spend working and practicing lying? As much time as possible. The Mansfield project, when I wrote that, it takes 3 months for a child to get used to a new lying position. So trying something for an hour and then deciding, no, they're not going to do it, just doesn't make sense. So think in your mind, it's going to take us about 3 months for this child to really get the hang of doing this. Would I use it in a child who already has, even in young children? Yeah, 100%. Absolutely. Even right, you've got 2 things happening. You've got risk factors, and then you've got the consequence. So GMFCS5, that's a massive risk factor. The research tells us where those kids are going. So don't wait for the consequence. If they have those risk factors but are symmetrical, get in there and protect that symmetry. Okay, don't wait. Like Gillian said before, horses, don't let the horse bolt before you get in. The apparatus we use is, so look at Nest and through Timian. It's available through South Africa and through DDO in other places. Supported sideline. We haven't got time to go into supported sideline. I completely understand. Right. So that we do have sideline positioners and things. Right. I'll do it tomorrow for you, Gillian.
Yeah, because I know it's a whole discussion on its own. Okay.
Yeah.
Sarah, thank you so much.